The Galen Center for Health and Social Policy, in collaboration with the Lung Cancer Network Malaysia, the Cancer Care Working Group, and the Pharmaceutical Association of Malaysia, organized a webinar on lung cancer and COVID-19, Should You Be Worried, on 29th April 2020. The webinar aimed to explore the link between cancer and COVID-19, address patient concerns on lung cancer diagnosis and treatment during this period, and to provide recommendations on the way forward from the perspective of clinicians on the ground. At this point in time, a nationwide Movement Control Order, or MCO, has been extended to May the 12th, 2020, which brings up to a total of 8 weeks of restricted movement imposed on the Malaysian population to combat the spread of COVID-19 in the country. The webinar is the second in a series on cancer care and COVID-19 that has been conducted thus far.
We have with us today, for today's webinar on lung cancer and COVID-19, asking the question, should you be worried? We have with us two eminent persons, Dr. Anand Sachithanandan, who is a consultant cardiothoracic surgeon and a co-founder of the Lung Cancer Network Malaysia. Also with us is Dr. Tho Lai Mun, who is a consultant clinical oncologist and who is also a co-founder of the Lung Cancer Network Malaysia. So to both of you, doctors, welcome to this morning's webinar.
Good morning.
Thank you. Thank you, Azrul. Morning.
So, one of the things that we'd like to start off by asking, before we get into the nitty-gritties of the discussion today, is where are you calling from, doctors? Dr. Tho?
I'm calling from my clinic, and actually my work has continued through the MCO with a fairly normal patient load.
So work hasn't stopped for you. It's basically continued on. There's nothing different before MCO and after MCO.
No difference, except everyone in the hospital where I work has to wear a mask. Staff, patients, visitors included, and patients who are going for surgery or being admitted get a COVID test prior to admission. And everyone is pre-screened by health declaration and also temperature checking daily.
Okay, thank you, Doctor. Dr. Anand, where are you calling from?
Hi, Azrul. Morning. So I'm also from my clinic here at Sunway Medical Center. And unfortunately, I can't be as enthusiastic as Dr. Tho. There's definitely been a reduction in our clinical workload, which I think we attribute to the Movement Control Order.
And what are has there been any change in the way that you've been operating at the clinic and the hospital?
Yeah, I think very much so. Some of the things that Dr. Tho just mentioned briefly, perhaps it gives an insight for patients or whoever's viewing or listening. I can share with you what's being done in our hospitals, and I think it's similar to all hospitals across the country, public or private. So the first thing that happens is everyone gets their temperature checked. It's either a thermal scanner, similar to what you get at KLIA, or a member of staff is going to manually check your temperature with a digital thermometer. As Tho Lai Mun said, everyone has to fill in a health declaration form, where essentially you have to disclose your contact and travel history. You have to disclose if you have any symptoms. Another sort of new normal, there's very generous offerings of alcohol-based hand sanitizers. And I think the hospitals in general have made a concerted effort to try and limit the number of visitors and the visiting hours as well. And certainly here at Sunway and SGMC, and I think it's the case with most hospitals, members of staff, the healthcare workers have been encouraged. It's almost mandated that we wear a face mask. And I think that's to try and lead by example. The other thing I can share with you, Azrul, is as we all know, if we just look at Klang Valley, I think we know the COVID-19 designated hospitals are mainly Sungai Buloh, obviously, HKL, and the University Hospital, UMMC. But that's not to say we won't see patients who are either suspected or unproven possible COVID illness. So most hospitals have already put in place, we have designated wards to try and separate potential COVID cases from non-infectious cases. What we would term is the PUI, a person under investigation. And the final thing, just in terms of, just as a starter, we have physical or social distancing measures in place. So the lifts, the elevators, there are spaces marked out that, there shouldn't be more than 4 people going into the lift. Even in the outpatient setting outside my clinic, and I suspect it's the same everywhere, if you have a row of 5 chairs, 3 of them have been X'd out. So, patients or caregivers can sit on either end. And the idea is just to promote and, that concept of physical or social distancing.
So basically, one of the things that we see is that in many hospitals and healthcare facilities today, many of the precautions that you've just mentioned that's happening at your hospital are being implemented across the country in a way to try to ensure that there is a breaking the chain of transmission of COVID-19, but also to ensure that everybody is able to not only protect themselves, but also protect other people who might be in their immediate circle, but also if they were to go back later on, also protect their families. So ensuring that you're not getting infected from the very beginning. So today's discussion, thank you both of you doctors. It's always interesting for people to note that, despite the emphasis that everybody has to stay home, we are sometimes forgetting that there are people like yourselves who are out there, continuing work as usual, like what Dr. Toh has mentioned, that life has not stopped. Life has perhaps even accelerated in terms of trying to continue with the functions that you were able to do before the MCO, and now you have to go through roadblocks to get to your place of work, show your sticker whether or not you're petugas kesihatan or not, and so forth. So it's become a little bit of a change for a lot of people, but for you, both of you sounds like, well, business as usual. Seems like patients are still coming to see you. So for today's purpose, we have the discussion on cancer, and specifically we're looking at lung cancer. And recently, the Lung Cancer Network of Malaysia published an op-ed which discussed the idea of cancer patients, specifically lung cancer patients, being much more susceptible or vulnerable towards getting infected, or perhaps much more vulnerable towards complications with regards to COVID-19. So both of you co-authored this particular op-ed. So we would like to ask you a little bit about it, which was published in Code Blue. And one of the things that you stated from the very onset is that new data suggests that lung cancer patients seem to be particularly vulnerable to COVID-19. Can you elaborate a little bit about that?
Yes, so the suspicion has been that cancer patients in general are more immunocompromised, and the treatments that they receive may also contribute to the immunosuppression by affecting the white cell count, in particular lymphocytes. Lymphocytes are the cells in our body that help to ward off viral infections. So data has come out of Wuhan as well as Guangzhou, which shows that cancer patients in general are 2.3 to 3.5 times more likely to be infected with COVID than the normal population. So they compared the statistics to people in the normal population within their community. And lung cancer patients were overrepresented in these figures. So in Wuhan, for example, 58% of the patients, the cancer patients, were lung cancer patients. So this could be from a variety of reasons. So lung cancer patients have a higher rate of smoking. So smoking itself causes more susceptibility to developing COVID. So weakened lungs or COPD also increases the risk of developing, of contracting lung infections. So just to move on from that, so if a lung cancer patient develops, so I just appeal to the participants, if you're not speaking, could you please mute your microphone? It's quite loud, there's quite a bit of background noise. I'm so sorry, but would you help us do that? That'd be great, yes.
It's okay, doctor, please go ahead.
So, so if a cancer patient develops COVID, they're actually 5 to 6 times more likely to succumb or die from the COVID infection compared to a normal patient. And this is data borne out of Wuhan, the WHO Joint China Commission study, as well as an Italian study that showed out of the 355 initial deaths in Italy, 20% had cancer. So these are striking statistics for us to consider when we look after cancer patients, and particularly lung cancer patients in general.
Thank you, Dr. Tho. But one of the things that was very much of an issue that leaked out from the article that both of you co-authored was the point that you made about the walking well. I mean, it's one thing for us to look at symptomatic patients and to be able to recognize that individuals who are symptomatic, you're easily able to detect and easily able to diagnose within a hospital setting. But there's also the issue of the walking wounded who may, as you say, spread the disease unknowingly. And you mentioned, again, in the article that was published in Code Blue, that in Malaysia, 80% of COVID-19 patients are asymptomatic or have only mild symptoms. So could you elaborate a little bit about that?
So perhaps I can just comment here as well. I think if we look at the global data, it is what's happening in Malaysia mirrors the global data, that the vast majority, we need a sense of perspective, and the vast majority of cases are going to be either mildly symptomatic or asymptomatic. So that is the challenge in how we detect the infection of the coronavirus in these cases. If we look specifically at high-risk groups, if we're talking about the care of cancer patients or healthcare workers, I think we're all familiar with a disproportionate number of healthcare workers, not only here, but say in the UK, in Italy, that have passed on. And it presumably has to be due to the viral load. They have more chronic cumulative exposure. So we have to find ways to try and mitigate and attenuate that risk, taking all the necessary precautions, which we've talked about, your personal protective equipment, which ranges from your N95 respirator, having a face shield or some form of eye goggle protection. We need to look at the option of even testing healthcare workers. Perhaps this needs to be done in a very sort of targeted manner. So, for example, healthcare workers who are looking after high-risk groups, those working in the operation theatre, working in the intensive care unit, dealing with cancer patients, dealing with dialysis-dependent end-stage renal failure patients. These are more vulnerable patient subgroups, and healthcare workers, perhaps we need to explore testing for coronavirus or COVID-19. The difficulty and the challenge, of course, is that, as we all know, you could be COVID negative at one time point, but there's no guarantee that you will go on to develop an infection later. What I can just share with you as well, Azrul, for example, if we have a patient who is coming for an elective procedure, even if it is a very low-risk procedure, such as a diagnostic bronchoscopy or an endoscopy, now in the setting of COVID-19, these are deemed to be high-risk procedures because of the potential for viral aerosolization, the spread to the healthcare workers. And similarly, the patient is going to go for surgery. So in this scenario, we would do a COVID test, ideally no more than 48 hours prior to the planned procedure. As we all know, at the present time, we are using the real-time PCR, which is deemed to be the most accurate, either nasopharyngeal or oropharyngeal swab. But even the best results, we're looking at a sensitivity of about 70%, 60, 70%, which means 1 in 3 could be falsely negative. So it doesn't substitute for clinical acumen. I think if we have patients who need to continue with their treatment, we cannot afford to defer on their treatment, i.e. lung cancer cases, then you do the COVID test. If the result is negative, but the clinical suspicion is high, it may be we have to repeat the test. And in some cases, perhaps even do a low-dose CT scan, because as we all know, coronavirus predominantly affects the lungs and the respiratory system. Not exclusively, but predominantly. So I think the whole idea is to mitigate the risk, protect the healthcare workers as much as we want to protect the patients as well.
But, one of the things one of the issues that's been highlighted, and I think Dr. Tho has touched onto it just now by looking at the cases from Wuhan, is that we see there to be an elevated risk of contracting COVID-19, specifically for lung cancer patients. And this is something that hasn't been explained very well when it comes to how a cancer patient could possibly be much more vulnerable. Perhaps either one of you could actually explain a little bit more on that, because there's a lot of talk about immunity, there's a lot about being immunocompromised and so forth, and a lot of data and learning is coming out from China. What can we actually take from China and bring into the Malaysian context? Is China different than what's happening here in Malaysia?
Maybe I can just... go on.
We have to remember that lung cancer in itself is the most common cancer in China. Their rates of smoking is much higher than Malaysia in general. So, in itself, epidemiologically, they have a very high incidence of cancer. So it's much more likely that a lung cancer patient would develop cancer. Would develop COVID in China. However, I think there are particular susceptibilities when it comes to contracting a lung infection if you already have so-called weaker lungs. So lungs which are more susceptible to infections that the immune system may not clear so well because of the nature of the lung structure, which has been damaged previously by smoking or being damaged by the process of cancer. I think Dr. Anand has also written about smoking and the risk of COVID. So maybe he can elaborate on that as well.
Yeah,
so I go to you, Dr. Anand.
Thanks, Lyman. Yeah, I think I just want to add 1 or 2 other points. The first is a lot of the data, all the data that we have really, there is observational data. It's retrospective. Okay, so that's just the nature of the evolving pandemic. There isn't an opportunity to do randomized trials. So we have observational retrospective data. Obviously, there are confounding factors. For example, perhaps, even among cancer patients, I think we all accept cancer patients are in a high-risk group. But even within that, it could also be confounded by additional risk factors. They may have higher incidence of comorbidities, for example, more diabetics or more hypertensives, or they may be slightly older. But as what Dr. Tho said, we all know that smoking, the vast majority of lung cancer occurs in a smoker or former smoker. They have a smoking history. And aside from, impairing the immune system, aside from damaging the lungs and giving us less pulmonary reserve or capacity to withstand a COVID illness, there are more specifics as well. For example, scientifically, we know that the coronavirus enters the human body, the human cell, through a receptor called the ACE2 receptor, angiotensin converting enzyme 2 receptor. Now, this has been established from the 2003 SARS viral outbreak, and this coronavirus, of course, is a variant of that. But they have been able to establish that the virus enters through the ACE2 receptor. Now, the ACE2 receptors are situated in a number of different organs or tissues in the body, including the lining of our blood vessels, what we call as the endothelium, as well as in our kidneys. But guess what? It's also found in the lining of our airways, what we call as the respiratory epithelium, and in certain cell types in our lungs called the type 2 alveolar pneumocytes. And I can share with you that there's been quite interesting research and data, very contemporary, that has been published in the last few weeks from China, from Western Europe, that has shown that smoking, we don't know which component, presumably nicotine, there appears to be a activation, upregulation, enhancement of the expression, the genetic expression of these ACE2 receptors. We have what is known as a nicotinic cholinergic receptors, and it is thought, one of the theories is that smoking actually enhances or upregulates the receptors. So in simple terms, what happens is, if we look at it just very simplistically, there will be an upregulation of receptors, so the coronavirus has more opportunity to invade. So theoretically, there's a higher chance for a smoker to contract coronavirus, and when they do get a COVID illness, theoretically, there's a higher risk of more severe illness, presumably because of a higher viral load. So that could also be a reason. I mean, in Malaysia, I would say at least 70% of patients who have lung cancer that Dr. Tho and I would see, at least 70% have a smoking history. So that there in itself could be one of the reasons why, by virtue of being a lung cancer patient and having a smoking history, you have an elevated risk of contracting coronavirus and potentially a more severe manifestation of the disease.
And what does it say to you about what you can see amongst lung cancer patients in Malaysia with regards to their disease profile? What stages are we looking at? Stage 3, stage 4, stage 2? I mean, at what point should a patient really be worried about going to a hospital to seek treatment in this time of COVID-19? Should they actually take active precautions? Because we are starting to hear that some patients are more worried about COVID-19 now than going to seek treatment for their condition. How do you respond?
So I think the former DG of Health, Dr. Ismail American, has also commented on this issue. I think we shouldn't throw the baby out with the bathwater. Certainly, COVID is very is at the forefront of our minds right now, and certainly there are quite a lot of fears concerning COVID. So I think it's mandatory. Firstly, it's absolutely mandatory for any healthcare facility that wants to continue operation in this climate to take extreme precautions in ensuring the safety of not only the patients but also visitors and staff. So I think that is mandatory, and that's done through testing, proper cleaning of high-touch areas, people wearing masks. So no compromises on health and safety. But at the end of the day, cancer, especially in the early stages, is potentially curable. And cancer is a time-sensitive disease. If you delay cancer treatment in a person who is stage 1, they then progress on to stage 2 and then stage 3. And at each increasing stage, you reduce your ability to potentially cure that patient. So I think for cancers which are potentially curable, we should really consider making facilities available for their continued treatment. Of course, both Dr. Anand and I practice in a private setting where resource and manpower, we are a little bit more at luxury to continue our services. In the government setting, where even consultants, oncologists are being rotated onto COVID wards and to man fever clinics, I think that there are limitations that way, surgeons especially, and in some designated COVID hospitals. However, I think the word on the ground is that, a month and a half ago, we were talking about closing services, but now we're talking about reopening services and including the government setting. So I think that's good news for our cancer patients, but I certainly understand there are resource limitations in the public sector.
Let me ask you then. So we have 100 people listening in to this webinar this morning. It's a packed house, and there's a lot of anxious patients who are trying to decide whether or not to go for treatment, whether or not to go to hospital, whether or not their treatment is even available still at the hospitals that they've been going to for the very beginning of their treatment, and perhaps they have to go to a different facility in order to continue on with their course of treatment. So I would like to just at this point ask that those who are participating in today's webinar to send their questions through the group chat, which is available as a function, and I will go through the questions and put forward to the speakers today. Please use the group chat to send your questions, and we'll get them answered by the doctors here. So I just wanted to put forward to both of you that particular concern, which is that we have interruption or deferment of existing treatment courses. Is this something to be worried about for patients who are concerned that if they're being deferred, not to next week, but to next month or even 2 months down, that there could be an upstaging of the existing condition?
I think,
Dr. Anand, go ahead.
I think the short answer to that, Azrul, is yes, we should be concerned. You know, I think the idea of waiting for the pandemic to pass and then we will resume normal clinical services is flawed. What we have done thus far is very reasonable, very sensible, but we need a sense of perspective. Globally, at the moment, there are about almost 3 million cases. It's been about 200,000 deaths. As we all know, in Malaysia, we are just shy of about 6,000 cases in total. And I think, unfortunately, we recorded the 100th mortality yesterday. That gives us a case fatality of about 1.6, 1.7%. Now, as to whether we're doing sufficient testing, that's a separate discussion. But in terms of prioritizing, I think cancer, as Dr. Tho mentioned, is time sensitive. So as a surgeon, I can share with you, for example, you know, when we are dealing with patients who have early stage disease, stage 1 and stage 2 lung cancer, we have this window of opportunity to intervene and offer what is potentially curative surgery. That often surgery is done as part of multimodality. They may require chemo, radio, immunotherapy before or after surgery. But the treatment, the principal treatment in early stage disease is surgical resection to remove that part of the lung. Now that confers the best chance of survival, the best prognosis, long-term survival for the patient. So what we have to do as clinicians and society at large, but more so the medical profession, we have to balance. We are trying to evaluate the risk if we were to defer definitive treatment or surgery, in this case for an early stage suspected or proven lung cancer. What is that risk of disease progression? How will that impact on that patient's survival or prognosis? Versus the risk of them contracting a COVID-19 illness perioperatively or upon hospital admission. And certainly I think, you know, the American College of Surgeons, the Royal College of Surgeons in the UK, even our own College of Surgeons here in Malaysia have cobbled together these guidelines and recommendations to try and help surgeons or clinicians triage and determine what would be, by definition, an elective case or an urgent or semi-urgent. What I would say to that, though, is that's very helpful, but at the end of the day, we have to individualize the treatment based on a case-by-case basis. We have to also look at the resources we have. So guidelines that may be very applicable and pertinent in, say, for example, New York, which is the epicenter of the pandemic in the US, is less relevant here in Kuala Lumpur, in Malaysia, where at the moment we have things under control. Now we have to remain vigilant, we can't be complacent. But if you have sufficient resources, intensive care unit beds, you have ventilators, you have the sufficient supplies of personal protective equipment, we have the capacity to do a pre-operative, pre-procedural COVID test, we are able to get blood products. Blood products are being scarce because of the MCO. So if we have all of this in place, there's sufficient slack in the system, then there's very little logical reason to defer offering the patient the treatment they need, be it early or late stage. You know, we try to mitigate the risk, make the hospital environment as safe as possible. I think what you said, Azrul, was spot on, that some patients are starting to get more frightened of a COVID illness than their own cancer. But the reality is the cancer is more likely to kill them. So they shouldn't defer the treatment indefinitely, no.
So we're talking about judgment calls that are being made by individuals, but also doctors who may not be able to see their patients. So what kind of aids or assistance are you providing in terms of, is there telecounseling? Is there telemedicine that we talk about quite often? How are we trying to overcome this distance in terms of the patient and the doctors today? I mean, what do you have in your respective hospitals? Dr. Tho.
Yeah, so yes, the obvious answer to that would be we can utilize telemedicine to a greater capacity in our day-to-day practice. I think for patients with active cancer, I mean, they require treatment fairly urgently and fairly promptly. However, there are another big cohort of patients in our clinics, which are the follow-ups. And I think the follow-ups in this COVID situation, quite a number of them can either be delayed for 1 or 2 months, so their routine scans or their routine follow-ups with us, sometimes even at 3 months. And we can keep in touch with them through the use of telemedicine. I think the Malaysian Medical Council has recently issued a statement saying they support telemedicine and that our medical protection societies will cover us if we take the adequate measures to consent patients and so forth to allow patients, to give patients information about telemedicine and use telemedicine. Telemedicine is not allowed to be used for first consultations. So that means we shouldn't use it to see new patients, but we should use it to keep in touch with our existing patients. If I can just take the liberty to quickly share a screen. Oh, sorry, it's been disabled. But there's a slide that I wanted to show that the average distance for a Malaysian to travel to a cancer center with radiotherapy is 83 kilometers. So where I work in the central region of Semenanjung, it's only 14 kilometers, but somewhere like the east coast of Malaysia is 124 kilometers, and in East Malaysia is 228 kilometers. So definitely we need some kind of remote access or remote communications with our patients, especially during this MCO.
So let's answer a few questions. There's quite a number of questions now coming in. It's coming fast and furious. First off, for patients needing radiotherapy, how are you managing these patients and what measures have you put into place?
So radiotherapy often involves patient coming up daily from Monday to Friday, sometimes for a week, for up to 6 weeks, 7 weeks. And when you visit a radiotherapy department, whichever cancer department, they have to practice social distancing. So you cannot sit within 2 meters of someone else. In Beacon Hospital, where I'm chair of the COVID committee, we've decided to have extra measures. For example, we will split patients into either a morning session or afternoon session, and we have split our staff as well to a morning session or afternoon session. So that means the morning session staff will treat the morning session patients, and they don't cross-interact with the afternoon session patients. So even more social distancing measures. Patients who start on radiotherapy, we implemented COVID testing on everyone. So everyone who comes up to Beacon Hospital for radiotherapy, for example, will get COVID tested. So they're operating or they're having treatment in an environment where everyone is COVID-free, at least for that period of time.
A question for Dr. Anand. There's a question here, patient with lung cancer who is due for chemotherapy but presented with fever, cough, but when they test using a PCR, it's negative. So what is your opinion? What is the next step that should be done? And if a chest X-ray shows that's suspicious for COVID-19, what should you do in that case?
So I assume we're talking about a patient with lung cancer who's had chemotherapy, either with a view to going on to surgery, what we call as neoadjuvant chemotherapy. Presumably that's why the question was addressed to me.
Yeah.
What's important is, it's a very good question. It highlights reality because, not all fevers equate to COVID-19. And as we've already established, cancer patients are probably more susceptible. I think you have to correlate it doesn't necessarily mean a negative COVID test means the patient is truly negative. So if your clinical suspicion is high, you have to perhaps repeat the COVID test. I think I mentioned earlier in one of the previous comments, one of the things in some places in the US they're doing is they're using it in some centers as a screening tool alongside the PCR, which is to do a low-dose CT scan. Now, I don't advocate doing that CT scan as a screening tool, but precisely in this scenario where we may need to try to ascertain more accurately whether the fever, could it be a surrogate of a COVID illness, then a low-dose CT scan will be very helpful because, you may see those classic changes that we see, which is those ground glass opacities, usually in the periphery, the outer bits of the lungs, and often in the lower lobes. And that you have to correlate with certain blood tests, looking at their white cell count, lymphocytes, repeat the COVID test, etc. I think these are very, very high-risk patients. We should be very judicious and meticulous in assessing them before we proceed on to the next stage of their treatment. So that is what I would suggest in that scenario.
Thank you, Dr. Anand. That is something that a lot of patients are actually wondering in terms of us learning more about the disease, and we're getting data coming out from Europe, from China especially, and I think COVID-19 is giving us more and more surprises, I think, in terms of how we are taking for granted looking at symptoms that would clearly identify it as being a COVID-19, and it turns out it's maybe SARI, but then you have to treat all SARI patients as COVID-19 as a default setting, just to be on the safe side. But at the same time, when you're dealing with lung cancer patients, then there are additional complications that need to be taken into consideration, and we still have to not eliminate the possibility that the person could be with COVID. So there is another question, and this is something that's quite urgent. I think both of you are starting to experience it because you are in private hospitals, and that is referrals from government hospitals for urgent treatment of some patients. Because right now, because of the reprioritization that's happening in the public health service, a lot of patients are being now referred to private hospitals and other government public hospitals. So are you seeing it happening over there at your healthcare facilities? I think a very important question that's being asked is, how are the treatment fees being worked out? Is it subsidized? Is it much reduced, etc.? Go ahead, both of you, doctors.
So maybe I'll just very briefly mention, in terms of, from a thoracic surgery perspective, we're talking about early stage disease. Certainly for Klang Valley, as we mentioned before, of the three officially designated COVID hospitals, right, which is UMMC, Hospital Kuala Lumpur, and of course Sungai Buloh, two of those three offer thoracic surgery. So one would assume that if they have patients with lung esophageal cancer, that they would be referring these patients out. The actual mechanism, of course, has to be worked out. I mean, I've had one or two patients that have been referred who have come over, but I think it's still very, very, we would have expected. One of the things we're wondering is, where are these patients going? And I think because a lot of the clinics aren't running as they should be in those hospitals, and of course there's no standard screening going on for obvious reasons, perhaps the pickup rate is less as well, what we call as those red flag referrals, patients with suspicious symptoms that warrant further investigation. So certainly from my personal perspective, we haven't seen much clinical workload being diverted to the private sectors for thoracic surgery in the context of lung cancer.
Dr. Tho, yourself.
Yeah, so the members of the Association of Private Hospitals of Malaysia have quite a number in the Klang Valley at least have signed up to offering pro bono services for government cancer patients to decant emergency cases or urgent cases to from the government setting, non-COVID patients, to have surgeries, etc., and so forth. But again, I mean, I don't know about other hospitals. We're kind of wondering, where are the patients? So they're not. We've not seen too many of these patients for some reason or other. In terms of chemotherapy and radiotherapy, I think different hospitals have different CSR options, and in Beacon, for example, we definitely have a CSR option for chemotherapy and radiotherapy, but I'm not so sure whether it is done pro bono for as a blanket rule. So I think it depends on the financial situation of each patient.
Yes, please go ahead.
So I think other hospitals do have provision to treat cancer patients for chemotherapy, radiotherapy as well during this COVID scenario.
So it really depends on the policies of the different hospitals then, on how they would actually charge based on what level of treatment and at what stage of the cancer then.
Correct.
Dr. Anand, you wanted to say something. Go ahead.
Yeah, no, I just wanted to echo what Dr. Zoe was saying, that I think most of us, certainly in the private setting, accept that, I think most clinicians are more than happy to offer pro bono services. But as most people know, the doctor's fees, the professional fees for procedure consultation is a very small portion of the total hospital bill. So really we need the other stakeholders, which is the hospitals, whether it's private, public setting, there has to be more integrated engagement to work out the financing of it. But I think it's something that's essential, because I suspect one of the reasons we're not seeing much volume is because of the MCO. But by definition, that tells us that, as a society, we're being reasonably compliant, that we are observing the MCO. We understand the need for it. And thankfully, so far, it's been working well. But, we need to have that exit strategy coming, say, in the next 2 weeks. If the MCO is partially lifted or more relaxed, possibly there will be, a backlog of clinical cases. And we need to have a mechanism in place how we can help our colleagues in the public sector, for example, particularly, we're talking about cancer work, surgeries that, as we've said before, can't be deferred for too long. So it's a distressing time for the patients as well. So I hope at a higher level, the discussions are already, have happened to the point that we have a pathway and a mechanism. I think it often comes down to the financing, unfortunately.
Yes, can I just...
Yes, please, go ahead, Dr. Do.
Just a quick comment to say that I think people may be under the impression that once the MCO is lifted, May, June, and we'll go back to business as usual. I think far from it. I think we have a new normal. I think there will be a big backlog in cases. I think we still need a very strong public-private partnership to really make sure everybody gets treated in a timely fashion.
But that backlog, which has been discussed by the former DG, Tan Sri Dr. Ismail Marikan, and he did say that because of so many deferred procedures being put to a later date, once we get to the point where the MCO has been lifted and people can then access their healthcare facilities much more free way compared to what we have right now, less restricted, how do you then deal with the backlog? Because obviously you have a situation then that they would want to clear the backlog first before going to accept new surgeries, new procedures that need to be carried out. So wouldn't patients then be anxious? I mean, if they were supposed to get their procedures done this month, now it's been told that it's going to be after the MCO is over, and then when they go back to seek treatment after the MCO, and they're told because they need to clear the backlog, they have to take a number, and the number means they have to wait another 2 months. I mean, how do you deal with this backlog? Because that is, I think, one of the worrying aspects of the MCO, because you can't just push everything back forever. There is a need to acknowledge that there are new cases that are emerging even as we speak. So how do you make a decision concerning which is more urgent, the backlog or the new cases that are coming in?
So I think in the government setting, there will have to be prioritization of cases as is the case now. So certain cases will take priority over other cases, where perhaps in the past, maybe they would be of equal priority. For example, prostate cancers, the radiotherapy required to cure an early stage prostate cancer requires daily treatment Monday to Friday for 6 to 7 weeks. So that's very, very heavily resource driven.
Yeah.
However, prostate cancer can be controlled by hormonal therapy, maybe not indefinitely, but at least for a few months to a year quite safely. And those kind of radiotherapy cases can potentially be deferred, whereas something like nasopharyngeal cancer, which requires treatment quite quickly, or lung cancer cases that require radiotherapy quite quickly, those need prioritization. So the other thing that I mentioned, that the good public-private partnership that is in place now, I hope not to see. I hope to see that it continues even post MCO. It may need to continue for another few months to even up to a year in order to offload the strain on government services.
I think this is a sentiment that has been echoed very much across the different healthcare sector, parts of the healthcare sector, which is the public-private partnerships need to carry us through the MCO, but also post-MCO. What do you
Beyond
think, Dr.
MCO.
Yeah, very, very much so. I think, just to follow on very briefly, what our former DG Tan Sri American said is spot on. Not only are we going to have a backlog to clear as a country of clinical cases, but by virtue of their treatments having been deferred, some of these patients may be in a less better shape. They need to be optimized. There may be disease progression. We may have more high-risk cases to do. That'll impact on the throughput, turnaround time. They may spend more time in hospital, more time in the intensive care unit as well. And how do we get around that? I think that discussion should be happening now. And certainly, as what Dr. Ayman said, we've got to have prioritization. So even if you look at the surgical workload in a given hospital, it's not just purely cancer work. So, an elective procedure by definition would be an operation that can be safely deferred for many weeks or months. An example would be someone awaiting a hip or knee replacement, perhaps a cataract operation. That's not to say that patient or that condition is not important, but it's probably, if you defer that, it's not going to be life or limb threatening. And there has to be a prioritization in terms of on a clinical basis. But there's only so much capacity in the system. So we really hope that, yes, there's more integration of public-private so that you can clear that backlog efficiently.
But I think I've had the chance to talk to a few cancer patients who are worrying about who decides. And it's left to the hospital, I presume, or the attending physician to decide whether or not this is urgent or not urgent, whether it's something that should be done now or can be done 2 months after the MCO is over. And they feel that it needs to be done now, especially when you talk about lung cancer, because we see lung cancer survival rates being so low in this country already as it is. And now there is a worry that because of the MCO, it's actually resulting in a much more depreciated level of survival for specifically lung cancer. So what do you say to patients like these?
The decision in terms of prioritizing an individual case, that has to be made by clinicians. So, for example, with lung cancer, whether you're in the private or public setting, most of the time it's through a multidisciplinary, what we call as a tumor board. So you may have a surgeon, you have a physician, a chest physician, a thoracic surgeon, an oncologist, pathologist, radiologist, and other specialists. So it is a multidisciplinary approach. It is very much evidence-based to determine for that individual case, for that individual patient, what is the best treatment option. And here, the treatment option may have been determined, but now the question is the timing, whether we can safely defer, who do we prioritize over the others when to clear the backlog. So that cannot be taken out of the hands of the specialist, the relevant specialist. But in terms of the mechanism of how we expedite the surgery, clear the waiting list for treatment or surgery, that's got to be made at a slightly higher level by hospital management, public and private. Because with the best will in the world, Azrul, we can say, look, these 10 patients need to be done in the next 6 weeks, for example, on clinical grounds. But if there isn't the mechanism to transfer them to another facility, then it's not going to happen.
So there needs to be a clear, transparent, and public announcement of the processes or the referral frameworks that are being used by all of the hospitals so that patients understand where they are in terms of these referral networks. Because right now, it really seems to be almost an ad hoc process, but also, them having to go through it first and putting themselves at risk before finding out that they have to go somewhere else to get treatment. So I wanted to ask Dr. To, you started off your presentation by mentioning about the cases in China. And there's a lot that we can learn when it comes to lung cancer, simply because of looking at what's available there in the Wuhan case and see how it's applicable here. So when you look at some of the lessons that we can learn from the Wuhan experience, particularly looking at lung cancer, what are the key points that you feel actually jumps out for you? Is there a higher risk for lung cancer patients to first contract COVID-19? Or second, once they have COVID-19, are they going to more likely develop complications which could actually result in a higher mortality? Is this something that we should be worried about? Because we hear from the Ministry of Health, their treatment regime right now has been quite successful when you compare to other countries. And the number of people who have been able to be treated successfully and recovered is much higher. Is there something that we are learning from China, but also we are seeing that is being learned here in Malaysia that we can transfer to other countries? Dr. To.
Yeah, so there are two questions there. I think one question was on cancer, what can we learn about cancer? And two is what can we learn about treating COVID itself? So in terms of treating cancer, COVID being the global pandemic that it is, so we see our colleagues across the globe struggling and trying to cope with new guidelines in order to stratify resources, stratify priorities for patients in terms of who gets treatment, who doesn't, across the globe. So we have actually international guidelines now, guidelines produced by the International Association of Lung Cancer, for example, through European and American guidelines. So in Malaysia, we can actually use that to distill their best practices and adapt that for our local setting, not just China, I guess. We know that in terms of lung cancer treatment, radiotherapy, for example, is quite safe. However, we need to put tighter restrictions on the amount of normal lung that gets radiotherapy, because the lung, if this patient then goes on to develop COVID at a later stage, if we do them a disservice by irradiating too much lung, they would then end up being more susceptible to succumbing to COVID. But in itself, radiotherapy is quite safe. Chemotherapy, we can modify our regimes to make it less immunosuppressive. That means using supportive medicines to boost up the white cell count to make sure it doesn't drop below a certain level. Immunotherapy is quite safe. Initially there was a lot of, a little bit of hesitation with using immunotherapy in this COVID setting, but it seems to be quite safe, and so is targeted therapy. So that's what we have learned from our colleagues in China. I was just at a webinar with one of our Wuhan oncologists a few days ago, and this seems to be the prevailing thoughts about it. COVID is a moving goalpost. We get so much new data every day. Hydroxychloroquine was meant to be effective from the French study, the Chinese study, but then the American study, which was bigger, but retrospective, showed that it wasn't so effective. But perhaps it depends on when you use hydroxychloroquine. It seems to be more effective in the upfront setting as opposed to the later setting. So we are getting a lot of different data that we need to integrate very quickly to adapt, be agile, and to adapt it to our practice.
I think that is definitely something that we are learning in the Malaysian setting as well with regards to the treatment regimes. When can you use hydroxychloroquine, and whether you can use that for the late stage. And we see a lot of them in the category 4 and 5 needing intensive care and ventilator support, and may not necessarily be able to be using that particular treatment and looking and learning from the French and American studies. But going back to the lung cancer concern on the side of what we can learn from the Malaysian setting, Dr. Anand, I'm sure you've seen the list of patients that have been publicized by the Ministry of Health in terms of who has passed away due to COVID-19. Are there any lung cancer patients there in terms of comorbidities?
I can't tell you off the top of my head, to be honest. I think what we do know is that, I mean, there have been some patients who are relatively young, and another group that stands out, you know, maybe not even just from Malaysia, but globally, is the healthcare workers, people who are deemed to be at risk. But the general, if you look at data from Italy and even from China, the well-known sort of risk factors, you know, demographic things like the older you are, and of course, the more comorbidities you have, like hypertension, diabetes, and so forth. For Malaysian data, I have to confess, I don't know if any of those include lung cancer patients. I don't think so, but that information also may not have been disclosed. But I think it's a fallacy to think, you know, we've seen cases in North America and Europe where seemingly healthy young people have also contracted coronavirus and got a very severe COVID illness. And it's a bit of what Dr. Tho was saying, we're learning almost on a daily basis. We think it largely affects the lungs and causes a severe, you know, pulmonary lung dysfunction. There's a lot of discussion in the medical community. We now are starting to recognize there's even, you know, it manifests outside the lungs, microvascular disease. There's even discussions about should all patients be ventilated, and if so, what is the criteria? When do you ventilate? When do you avoid ventilation? Perhaps the need for anticoagulation as well, to have a low threshold. So there are certain parameters, biochemical as well as clinical parameters that we look at, or that the intensivist treating these patients will look at. So it's a rapidly changing landscape as well.
It seems like we're learning something new every day with regards to this COVID-19 disease, but also how it affects people who are living with other chronic conditions, and whether or not it affects their ability to not just live normally, but also survive lockdowns, the MCO period, and so forth. So there's a lot that we can learn. So both of you are co-founders of the Lung Cancer Network Malaysia. And I think it's safe to say that being an organization that looks out for the interests of lung cancer patients, are you looking forward to perhaps a collaboration between private and public hospitals to address urgent needs of lung cancer patients who perhaps are experiencing a delay in their treatments? Are you looking forward to forming a collaboration, or at least highlighting this issue a lot more?
Very much so, Azrul. I think, you know, and we're very appreciative of this invitation to participate in this webinar. I think just getting the message out there. I mean, I can share with everyone listening in, for example, just away from COVID for a brief moment. One of the things LCNM did last year is we engaged with 7 or 8 major private hospitals in the Klang Valley region and one in Malacca. And we were able to twist some arms and get free low-dose CT screening. So the science and technology is there. There's level 1 scientific evidence that if we offer low-dose CT screening to detect lung cancer at an earlier stage in high-risk groups, which are basically smokers and former smokers of a certain age group, certain duration, that we can detect the disease earlier. So that's an example of what we've done as an NGO, trying to, you know, pave the way for screening to detect the disease earlier. Because in Malaysia, as we all know, about 93 to 94% of cases, you know, the most contemporary data we have from the National Cancer Registry report, 2012 to 2016, 93 to 94% of cases are picked up in stages 3 and 4, where, you know, the outcome, despite tremendous advances in chemo and radio and immunotherapy and targeted therapies, it's still non-curative. So if we can pick it up early, the outcomes are much better. So that's an example of what we have done, trying to promote screening. Certainly we would welcome and help to collaborate with, you know, but I think it has to come from the healthcare providers. So the regulator being the Ministry of Health, as well as the private hospitals. Our role as an NGO is to provide advocacy and guidance and shamelessly, you know, fly the flag for lung cancer for patients, for survivors, and promote the science in an unbiased sort of manner. That's what we're about.
I think you're right. You know, we also don't hear enough about lung cancer in this country, despite it having a low survival rate. I think it needs a little bit more attention, and certainly a lot more support in ensuring the level of treatment and care that's possible with the existing technology and innovation that's available. Dr. Tho, I give you basically the last word. Go ahead.
So, again, thank you so much for the Galen Center for organizing this and producing very, very high level policies and thinking surrounding a lot of healthcare issues. My final word is, I mean, I think we have to put things in perspective. I think cancer in this day and age is treatable, and especially if you have an early stage cancer, we are aiming for cure. So I think we should not be too sidetracked with COVID, but obviously you need to speak to your doctor and look at the avenues for best treatment possible, and don't delay within means. You know, obviously resources are stretched, but we still are able to treat patients. I mean, as doctors, our default position is to advocate for our patients, and when we advocate for our patients, we are aiming to give you the best treatment possible. And our cases in Malaysia are declining, our services are opening up, MCO is being relaxed. So I think right now is a good time to actually to not delay treatment and get the treatment as per required.
Well, you know, I think that is a really good way to end this session, this webinar today. I think certainly wanting to ensure that we don't compromise on the level of quality of treatment for cancer care, and for us to not take our eyes off the ball, as it were, when it comes to cancer, despite the fact that COVID-19 is such an overwhelming and overarching issue at the moment. But the fact is that cancer, it will continue on and will be beyond the MCO, and certainly we will be coexisting with COVID-19. So I just wanted to thank both of you, Dr. Anand and Dr. Tho, for participating in today's webinar, and certainly thank you very much for sharing your insights on this very important issue, and for helping to answer some of the questions that have been forwarded by our participants here today. And I certainly hope that both of you, in the course of your work, you will continue on to do the best you can and stay safe, and to be able to look forward to a much more better outcome after the MCO is over. I know it's not easy for both of you to spend your time with us, so I'm very thankful for the Lung Cancer Network of Malaysia also for you know, being able to spend your time with us. Thank you very much to all of you.
Thank you so much.
Thank you for the kind invitation, Azrul.
Yeah. Thank you to all, and certainly we have had 100 participants for today. We will be having more webinars coming up in the near future, and we certainly will be announcing them on our Facebook account. So if you have not joined the Facebook, if you have not shared or joined or liked the Facebook account for the Cancer Care Working Group, please go to the Facebook page and like that page. So with that, we end today's webinar. Thank you very much, and stay safe and take care.